some more. I'm going to introduce a second speaker, who is Dr. Jameela Sathar. She's going to talk about intravenous iron therapy as a standard of care in oncology. Dr. Jameela Sathar is a consultant hematologist and former head of service in hematology in Malaysia, where she is responsible for the care of patients with thalassaemia, haemophilia, thrombosis, and bleeding disorders. She was instrumental to developing national thalassaemia and haemophilia programs to improve the care of these patients in Malaysia. And she's also actively involved in promoting patient blood management programs to optimize patient outcomes. Just to let you all know, she's actually the pioneer, and patient blood management is actually her brainchild. Dr. Sathar is also a member of many professional societies, including the Bloodless Medicine and Surgery Society, and also International Society of Thrombosis and Hemostasis, which she managed to get of my PBM booth in this ISDH Bangkok, 22nd to 26th of June in this year. So, and she's also the former president of Malaysian Society of Patient Blood Management, which I need not to introduce more. So, Dr. Sathar, I will pass over the floor to you. Thank you.
Thank you, Mandy, for the kind introduction. And I'd like to thank Nathaniel and his team for inviting me to talk to you on the next topic, which is IV iron as standard of care in oncology. Let me see how I can put this on. Can you see my slides?
Yes.
Yeah,
Yes.
but I have to
Yes.
put it. I have to put it on
Slideshow.
Slideshow. Yeah, because it's hidden here. Okay. All right. Okay. Hi. Thank you, Mandy. Thank you, Nathaniel, for inviting me to speak to you. To all of you here this evening, I have no disclosures. And I'd like to say that iron deficiency is common across all disciplines and in oncology too. So we'll be focusing on oncology. And let us look at the prevalence of iron deficiency anemia in cancer or in oncology. So from the European Cancer Anemia Study, they looked at over 15,000 patients with cancer and found that iron deficiency was seen in 54% of patients at presentation. And that went up to 75% during chemotherapy. And as you know, during chemotherapy, patients, they become unwell, they may be vomiting, they can't take in well, nutrition, they can't take in good nutrition, they may have infections. So a lot of factors are involved in causing the anemia in patients who are also with cancer was also on chemotherapy. And they also found that iron deficiency anemia is 2 times more common in hematological malignancies versus solid cancers. And iron deficiency anemia in these patients can be either functional or a combination of both absolute and functional iron deficiency. Looking at another study by Ludwig, it's a study done in Austria, Vienna, Austria, looking at the prevalence of iron deficiency in the different subtypes of cancers. This involved over 1,500 patients, and they found that patients with pancreatic cancer has the highest prevalence of iron deficiency as well as iron deficiency anemia, followed by lung cancers. Hematology cancers account for about 50% of the patients with hematologic cancers have iron deficiency. So we went on to look at our own center, Ampang Hospital, which is the National Referral Center for Hematology in Malaysia. We just looked over 3 months from July to October 2023, whereby we actually do bone marrow aspiration and biopsies for all our patients at presentation, all our patients with hematological malignancy at presentation. we had 55 bone marrow samples, of which 25 were female and 30 were male. And of these, 56% are diagnosed with leukemia, followed by 29% lymphoma and 15% multiple myeloma. So for all these bone marrows, we also do a pearl stain to look at the iron stores. So the picture on the left is absent iron stores. You see that there is no bluish coloration, which signifies iron within the bone marrow fragments, while the picture on the left shows normal iron stores. You can see the blue particles there. That's iron. So the picture on the right is normal iron stores. The picture on the left is absent iron stores. So we looked and went through all, these 55 samples and found that, actually to our surprise, 76% had low or absent iron stores. And what is more surprising is males actually had, there were 77% of males having low or absent iron stores, and compared, which is actually equivalent to the females. So I was pretty surprised because I was expecting males to have, about 30%, females about 50% absent iron stores. So only 14%, you can see on the graph on the right, had adequate iron stores. So, so 76%, having absent or low iron stores, that's a lot, to our surprise. At presentation, all our newly diagnosed hematological malignancies at presentation had low iron stores to begin with. And you imagine if you give them chemotherapy, what will happen? I think almost all will develop iron deficiency anemia, right? And in hematological malignancies, the chemotherapy is very intensive. So, okay, so, well, iron deficiency is common, yet it is not addressed in patients with cancer. This is a study, comparing patients who are on dialysis, receiving iron tests, and those receiving IV iron, compared to patients with cancer receiving iron tests, and those patients with cancer receiving IV iron. So the cancer patients are the one in red, while dialysis patients, kidney dialysis patients are the one in blue. And you can see the trends in iron testing and IV iron dosing is much higher in patients who are on dialysis as compared to those to patients with cancer. Hardly any patients have iron testing, and then you can see those receiving IV iron is actually going down in patients with cancer. From 1992 to 2001, the patients receiving IV iron is actually falling down. I think most of these patients are getting blood transfusion. So the myths in oncology and hematology, most of our hematology oncologists or hematology oncology doctors who are treating hematology oncology, they feel that if we give iron, the cancer cells will feed on the iron, so promoting cancer growth. And they also feel that iron increases the risk of infection and mortality. And also iron increases the risk of cancer relapse. These are all the myths that they perceive, in oncology, within the oncology and hematology fraternity. But there is no evidence to back this up. On the other hand, we have so much evidence to show that actually blood transfusion promotes cancer growth, increase the risk of infection because of the immunomodulation, and increase the risk of mortality, increase the risk of thrombosis, and increase the risk of cancer relapse. And we have heard from Dr. Neil's talk yesterday, and also from Dr. Rafai's talk, all complications of blood transfusions in patients with cancer. So we will debunk these myths, And another thing, the hematologists are actually okay in giving the granulocyte colony stimulating factor, yeah, which you would think that it may also promote the growth of the leukemia cells, but they are just using it so freely. So why can't we be using IV iron to treat iron deficiency anemia, yeah, rather than using blood transfusion? So what are the consequences of anemia in cancer patients? Yeah, it impairs organ function, it reduces quality of life, there is greater post-operative mortality, of course, greater probability of blood transfusion, following chemotherapy, and of course, a shorter survival. Yeah. Okay, and what are the predictors of anemia following chemotherapy? For females, it's a low initial hemoglobin of less than 12.9. In males, it's less than 13.4, based on a study by Barrett Lee. And those with lung or gynecological cancers, yeah. Those who are on treatment with platinum chemotherapy, platinum causes, yeah, bone marrow suppression, and female gender. All these are predictors of anemia following chemotherapy. So why is it important to treat cancers to anemia and iron deficiency anemia in cancer patients? Because anemia in cancer has an adverse prognostic factor. It reduces survival. And of course, it's a risk factor for blood transfusion. Cancer causes cancer-related fatigue, and it reduces the tolerance to therapy. Yes, it's so important. It interferes with dosing and timely administration of treatment regimen. So you know that if you cannot give the, if the patient cannot receive a good chemotherapy regime, if they have to reduce the dose or they have to reduce the timing of the chemotherapy, that will actually reduce the risk of remission, yeah, and reduces the cure of cancer in these patients. And it also reduces, anemia also reduces motivation to continue therapy. And so most of these patients fall out, yeah? They don't come for the next chemotherapy and they're lost to follow-up. So it's so very important to treat cancer-associated anemia or iron deficiency anemia in cancer. So what does the guidelines say about the treatment and monitoring of iron deficiency in cancer patients? So I've put up the 4 guidelines here, and I picked the ASCO guidelines in 2019 saying that iron profile monitoring is recommended. Iron replacement is recommended if there's iron deficiency. Yeah. And the ESMO and EORTC guidelines also say that iron monitoring is recommended, and iron replacement in patients with iron deficiency produces increments in hemoglobin and reduces the need for transfusion. That's the ESMO guidelines. So all these guidelines recommend patients with cancer should undergo iron profile monitoring and treatment or replacement of iron if there is iron deficiency. Not just anemia, yeah? You can have iron deficiency without anemia. So a study by Noam looking at increases in hemoglobin with erythropoietic stimulating agent alone versus erythropoietic stimulating agent with IV iron. So this is actually a study to look at the various study from 2004 to 2011, showing you that if you give only erythropoietic stimulating agents alone, you wouldn't achieve the response that you want. So erythropoietin stimulating agents alone has a reduced response, yeah, in hemoglobin increment, yeah, as opposed to giving IV iron. So it tells you that IV iron is needed, yeah, in treating patients, in treating anemia in cancer patients. So IV iron, yeah, is important in erythropoiesis. Yeah, erythropoiesis is the primary consumer of iron. So erythropoietin is needed in the early maturation of your red cell precursors in the early development phase, while iron is needed in the later maturation of your proerythroblasts and erythroblasts. So you need these two to complement each other in patients with cancer-associated anemia. Yeah, but most of the time, yeah, they have both patients with cancer have
I think we
Iron,
can go ahead.
functional iron deficiency and absolute iron deficiency.
Apan, can you
So
take
what you do is
proceedings?
you would correct the absolute iron deficiency iron first, and then we add on erythropoietin. So IV iron. So how do I dose IV iron? So that depends on the urgency to correct deficiency. Yeah. Of course, if I want to get the hemoglobin up quickly, I would give a bigger dose. If the patient's in the ward, is inpatient, and then you know that they're going to be in the ward for about 2 to 3 weeks, then I would give a lower dose as opposed to when patient is outpatient. Yeah. And of course, for absolute versus functional iron deficiency, I would give a lower dose for the functional iron deficiency and a higher dose for the absolute iron deficiency. There are different, there are various iron formulations, yeah, venofer, osmofer, monofer, and pharynget. For the outpatients, I'd rather use, I use the higher dose, higher strength, while with patients, inpatients, I'll use the smaller IV iron formulation strength, such as venofer. So what I'll do is I'll share with you 2 cases, yeah. The first case is a 46-year-old lady, married with 4 children. She presented with abdominal bloating for 1 month duration, and a CT scan showed a uterine mass with endometrial thickening. And this was the mass. You can see there's a uterine mass. And she, so she was seen by the surgeon in a hospital, and it was noted, and she was actually planned for a biopsy, for a laparotomy. Her hemoglobin was 6 at presentation, and unfortunately, she was transfused 4 packed red blood cells before the op. She developed urticarial rash with a 3rd bag and fever during the 4th bag transfusion. Yeah. So she was planned for laparoscopic removal, but findings were an ovarian mass with pelvic nodes. So they proceeded with a total abdominal hysterectomy and bilateral self-involved oophorectomy and pelvic node clearance. And the HPE of the mass turned out to be Burkitt's lymphoma. Yeah, and so she was referred to the hematologist, and at presentation to us, her hemoglobin was 9.3, total white 9.6, platelet 369. She was planned for 3 pairs of rituximab A block, B block, which consists of very high dose methotrexate alternating with high dose cytosine arabinoside. So in the first 3 cycles, she was treated by a different team. She was admitted after the 4th cycle of chemotherapy under my care. She was recovering from sepsis with a hemoglobin of 6.2, and she was continued on antibiotics. Yeah, and I started her on IV iron, erythropoietin, folic acid, and vitamin B12. No blood was transfused, and she remained well and in remission until today. So this is I plot out the full blood count trend. So for the first 2 cycles of chemotherapy, there is A1, B1, A2, B2. You can look at the hemoglobin. She started off at 9.3, and then the lowest it went was 5.5. Yeah, yeah, and she had also another one at hemoglobin at 5.7. Yeah, and you can see that during this time, 900 plus 300 plus 800. 2 liters of blood was transfused in the first 2 cycles of chemotherapy alone. So she came to us, with a HB of 6.2. That's the yellow. I've put that in yellow. Yeah, the hemoglobin was 6.2 when she came to us, and Mandy and myself, we managed her. Yeah, she actually was not keen for blood transfusion. Of course, we didn't think of it. Yeah, because she was telling me if she was in the other team, she would be transfused blood, and she was not too keen because she gets reactions with the blood transfusion. So we started her. We gave her IV iron. Yeah, we gave her IV iron, and then we added on erythropoietin stimulating agent. We also put her on GCSF. And you can see when she had the last pair of chemotherapy with us, a hemoglobin ranged around 9.5. The lowest was 8.3. Yeah. And we continued on, yeah, with IV iron and erythropoietin stimulating agent throughout her stay in the hospital and on discharge as well. And you can, and when she completed chemotherapy and came on follow-up, that was a month later, her hemoglobin has gone up to 12.3, but she still remained iron deficient, and we continue on with oral iron. So the lessons learned from the first case is that, yeah, before chemotherapy, we should screen for iron deficiency, correct iron deficiency with IV iron. That's pillar 1. During chemotherapy, we treat functional iron deficiency with erythropoietin stimulating agent and IV iron, and reduce blood taking. That's pillar 2. Yeah. And after chemotherapy, we accept a lower hemoglobin level, and we give her a bolus dose of erythropoietin stimulating agent and IV iron before discharge, and before bringing her back, yeah, for her next chemo in a week's time. So that's pillar 1, pillar 2, pillar 3 that we follow, yeah, during the course of treatment for this patient. So case 2, we come on to case 2. It's a 65-year-old Malay lady, presented with generalized swelling in July 2016, and she was diagnosed to have nephrotic syndrome, and the biopsy showed minimal change glomerulonephritis. She was noted to have a high hemoglobin of 19.8, hematocrit of 61.2%, white blood cell 11.2, platelet 456, and a creatinine of 53. So we sent a JAK2, and that came back positive. She also had a bone marrow examination done. The diagnosis confirmed polycythemia rubra vera, and she was started on oral hydroxyurea and cardioprin. And she remained well on follow-up with a hematocrit between 45 to 50%. Yeah, that was, then she came back 3 years later with a hemoglobin of 11.5. Yeah, a lower hemoglobin and a hematocrit of 35%. And a white blood cell count of 14.8, platelet of 599. And clinically, she was pale. There was no palpable or enlarged spleen on ultrasound. So this was a blood film. Yeah, as you can see, there's a nucleated red blood cell. It's teardrop. Yeah, sorry, maybe I can show. This is nucleated red cells. The nucleated red cell. That's teardrop, and these two are blasts. Yeah, yeah, and these are platelets. Yeah, so, and this is a large platelet. And her red blood cells looks like there is a dimorphic picture. Some cells are pale, some are small, some are large. Yeah, some are large like this. It's a dimorphic picture. A bone marrow biopsy was then also done, and which showed hypercellular bone marrow aspirate with no increase in blasts. This is CD34 stain. This is the megakaryocytes in clusters, and this is the reticulin stain showing that there is fibrosis. Yeah. Then we also sent the 37 gene next gen sequencing and found a new TEC2 somatic variant mutation. So, so this points to progression of this disease. So she was started on JAK2 inhibitor, which is ruxolitinib. Yeah. And however, hemoglobin continued to fall. Hence, hydroxyurea was reduced, thalidomide was added on, zincofer, which is oral iron, was added, cardioprin was continued, and she was started on erythropoietin 10,000 units once per week. She actually came to see me early in January. Okay, so this is her full blood count trend. So when she was started on a JAK2 inhibitor, hemoglobin was 10.2. Yeah, and that actually fell to 9.4. That's when she was started on erythropoietin stimulating agent. So she came to see me in early January at my home, actually, because she knows she wanted a second opinion. So she came over to my home in early January, and I suggested that we should, start. She should be on IV iron as well, because this points to iron deficiency anemia. So I told her to get an iron test iron studies done, and also to actually look for a source of bleeding, right? However, she came back later towards the end of January with a further drop in hemoglobin, up to 7.3, and she was transfused with 1 unit of packed red blood cells in the by the treating hematologist. So what could be the cause of a drop in hemoglobin? Could it be the effect of the cytoreductive agent, progression of disease, transformation of disease to blast crisis, or occult bleeding? It could be a combination of any one of these, right? But we should always look for any bleeding. So the iron studies was only sent in February, and her serum iron was low. T-sats was low. Ferritin, of course, is acute phase reactant, was high. And the reticulated hemoglobin was 26, which is low. Anything below 30 is iron deficiency. And the stool occult blood was positive. So she has some bleeding somewhere. So she she went on to have an OGDS, upper scope, which found an erythematous and edematous mucosa with erosive pangastritis and a peptic ulcer and an ulcer in the antrum. So the diagnosis was peptic ulcer disease, and she was started on lansoprazole. There was no active bleeding at that time. She also had a colonoscopy, which showed 2 small ulcers in the terminal ileum, and the biopsy came back as benign ulcer. So the lessons learned from case 2 is to not always assume that the anemia is due to underlying hematological disease. Look for other causes of anemia, and it's important to screen for iron deficiency in patients with malignancy. That's pillar 1. So in summary, anemia is common in cancers, solid cancers as well as hematological malignancies, and increases with chemotherapy. Iron deficiency, both absolute and functional, is the most common cause of cancer-associated anemia and chemotherapy-induced anemia. It is important to screen for iron deficiency and anemia in patients with cancer. It should be routinely done. And anemia negatively impacts survival and reduces quality of life. IV iron improves erythropoiesis and reduces the need for blood transfusion in patients undergoing chemotherapy, as I've shown in the first case. So with that, I'd like to end with this slide to say that iron deficiency is everyone's business, and in oncology, it's as high as 50%, and you can see in hematological malignancies, as high as 80% of patients suffer from iron deficiency. With that, I thank you. That's the end of my presentation.